Good day to everyone. I'm very privileged today to be given a chance to deliver a topic. And the topic given to me is preparing CKD patients for surgical procedures, useful tips. I would like to start a bit about defining what is chronic kidney disease. Hippocrates said 400 years before Christ's birth, when bubbles settle on the surface of the urine, they indicate disease of the kidneys, and that complaint will be protracted. KDIGO 2012 defined CKD in two areas. This is defined as abnormalities of kidney structure or function, present for more or equal to 3 months with implications for health. So if you look at the table 2 here, there's a criteria for CKD, and they must be present for 3 months or more. Structural damage includes markers of kidney damage, albuminuria more than 30 milligrams per day, urine sediment abnormalities like hematuria, red cell cast, electrolyte or other abnormalities due to tubular disorders, and of course abnormalities detected on histology by performing a renal biopsy. Structural abnormalities detected by imaging studies such as ultrasound, CT scan are also considered CKD, and when you have a history of kidney transplantation. The second area that defines CKD is a function decrease, which we use glomerular filtration rate or GFR, and this is defined as a GFR of less than 60 mL per minute or equivalent to CKD 3 or below. I would like to bring everybody's attention to this chart, which showed prognosis for CKD by GFR and albuminuria category. So this is also extracted from KDIGO guidelines 2012, and most of the time we define CKD by the CGA classification, which is C for causes, G for glomerular filtration rate, and A for albuminuria. If you look at this chart, we have a level of albuminuria of A1 to A3, when A1 is the most mild kind of albuminuria and A3 is a severely increased. And here is the traditional CKD categories that we are all well versed with. G1, G2, G3, A, 3B, G4, G5, which is defined by your GFR of more than 90 for grade 1, 60 to 89 for grade 2, grade 3, 30 to 59, grade 4, 15 to 29, and grade 5 of less than 15. As you can see, as the grade deteriorates, go down the bar chart, you can see that actually the color of the code becomes from green to yellow to orange and red. So if it's green, it's actually low risk, yellow is moderate risk, orange is high risk, and red to deep orange is very high risk. We are talking about the risk of progression of CKD. So as a general rule, if you have advanced CKD, or we say CKD of GFR of less than 60, means 3 or below, 3, 4, or 5, and you have albuminuria, the more heavy albuminuria you have, the more likely you're going to progress in your CKD category. How about Malaysia? We have a recent published data of Malaysia, how prevalent is chronic kidney disease in Malaysia. And this is published in BMC Nephrology and is divided by the CKD stages. So if you look at the data, we have a total CKD of prevalence of actually 15%. And you look at stage 1 is about 3.85%, stage 2 is about 4.82%, stage 3 is about 6.48%, and when we reach stage 4 or stage 5 CKD, which is GFR of 30 or below, is about 0.33%. And this is Malaysian data. Coming to the main point of my talk, why is CKD important in surgical patients? And as nephrologists, we always and very frequently get referrals from our surgical colleagues or even orthopedic or ONG colleagues about our CKD patients who need to undergo certain surgical procedures, and they are always in a dilemma how to manage this kind of patients. So they are at increased risk of adverse outcomes and perioperative injuries, and this is mainly due to three main factors. Number one, hemodynamic instability during perioperatively. They are prone to get hypovolemia, and because of multiple drugs they are taking and also administrative of other medications perioperatively, they are more prone to be affected by effects of medicine. And this can lead to higher risk of progression of CKD, end-stage kidney disease, and reduced long-term survival. For perioperative considerations, we must understand that actually chronic kidney disease, CKD, is an independent risk factor for perioperative acute kidney injury on CKD, cardiovascular events, and eventually mortality. So before we embark on surgical efforts, surgery, we should say that before we proceed to do any surgery for this kind of patients, we should actually make an effort to focus on identifying patients with CKD and stratifying them according to the degree of kidney impairment and the type of surgery they are actually supposed to go through. So we come to the practical part of it. Who are the patients we need to screen in this category? So there are clinical factors as well as social demographic factors. And for clinical factors, the things we look at is the daily things that we always screen. We look for presence of diabetes. We look for hypertension. Any signs of cardiovascular disease. That's why we do baseline ECG and chest X-ray. And obesity is obviously a risk factor for most of the conditions. Any signs of autoimmune diseases? Are they known case of SLE? Do they have rheumatoid arthritis? Systemic infections? And of course, exposure to certain medications that are prone to promote kidney injury. And I will go through this later on, the list that we are entertaining. And if the patient recently recovered from an episode of acute kidney injury, they are actually at more risk to develop another episode of AKI, and this should be taken into account. Of course, when there is a familial history of chronic kidney disease, that is also a risk factor. Social demographic-wise, elderly are at more risk because of reduced renal reserve, and when they are having exposure to certain chemicals or environmental factors. Low income and education is also one of the factors, and of course, we Asians are one of the social demographic factors of chronic kidney disease. As what to check for, as usual, you look for your vital signs, your BP, your pulse rate, and also your hydration status. That is actually to ensure the patient is mainly euvolemic and not hypovolemic or dehydrated. And the list of medication that you need to go through, the list is not extensive, but the medications that you should be aware of, as I know some of the audience may not be from the medical department. So if you have a ACE inhibitor or ARB on board, you should actually stop that prior to surgery. And ACE inhibitors generally ends with prils. So it could be things like captopril, lisinopril, perindopril, and we have ARBs, which usually ends with sartans like telmisartan, irbesartan, and all these medications can actually potentiate AKI. Diuretics, because they act by promoting diuresis, and this could potentially lead the patient to a state of hypovolemia. And these include loop diuretics, thiazide, and potassium-sparing diuretics. Examples, common ones we see in the ward, furosemide, hydrochlorothiazide, or this spironolactone. For surgical-wise, I think the medications commonly prescribed are NSAIDs, COX inhibitor, COX-2 inhibitor. This preferably should be avoided as well perioperatively, because they actually promotes more risk of AIN as well as acute kidney injury perioperatively. One of the interesting medication that has sparked some attention lately is whether we should withhold SGLT2 inhibitors, or so-called sodium glucose transporter 2 inhibitors. which usually ends with glyphosines. For example, we have empagliflozin, dapagliflozin, canagliflozin. So these medications are also believed to promote some degree of diuresis and cause some hypovolemia. So people believe nowadays that when you are admitted for certain stress events like a surgery or when you are unwell, you should actually temporarily withhold this medication until you get better. And what to test for? Yeah, I would say, because I put the hell yeah there, because serum creatinine after so many years is still the most, I would say, small molecule that has stand the test of time, and that is not the ideal thing we test for, but then it's still the best test that we have, which is easily available and readily available in every, I would say, every laboratory lah. So even our estimated GFR to estimate what is our CKD stage, it also the formula is also derived using creatinine. So I would say, although it is not an ideal molecule, it is easily available and it reasonably gives us a good idea on the kidney function. So it's still serum creatinine, and if you have a baseline creatinine, which patient is well before the operation, that will be the best, and that gives you a rough idea what is the kidney reserve like before the patient embark on a surgery procedure. If possible, urine protein quantification is important because that gives us the idea of the albuminuria category and the risk of the CKD progression. So up to you which test you want to do. It could be a urine, just a full examination, a microscopic examination. It could be a urine protein creatinine ratio, even an albumin creatinine ratio, but the gold standard is 24-hour urine protein. Yeah. So we can do some fasting blood sugar, random blood sugar, HbA1c as well. That is just to look at the control of sugar lately lah. Yeah. And does the type of surgery matter? So is it all the patients that go for surgery has the same risk? The answer is definitely no. According to literatures, surgery at high risk of causing AKI mainly are cardiac surgeries, so coronary artery bypass, valvular repairs, all these are at high risk of AKI or acute kidney injury, and it's quoted 30 up to 70% of cardiac surgeries and also vascular surgeries. Do note that there's recent changes in surgical techniques like off-pump CABG, endovascular repair, and this has may have an influence on the post-operative renal outcomes. And patients undergoing endovascular abdominal aortic aneurysm repair seems to suffer less frequently from post-operative renal dysfunction, and the mortality rates are reduced compared with open surgeries. But just need to note that if the patient goes for endovascular techniques, there is a requirement to use contrast agents, and these contrast agents could be acting as nephrotoxins, and they can cause actually contrast-induced AKI. Coming to what to do for these patients, so this is extracted from a review article in 2016 from Mersch, and target is actually to discontinue all nephrotoxic agents. So this would include the medication list that I have given before this. If possible, avoiding radio contrast agents, avoid colloids if possible, use crystalloids, and especially starch-containing colloids is no-no. And volume status and perfusion pressure is very important. So the mean arterial pressure of more or equal to 65 millimeter mercury or higher, CVP of 8 to 12, maintaining a central venous oxygen saturation, maintaining intra-abdominal pressure of less than 50 millimeter mercury. All these are basically just reiterate that volume status is very important perioperatively. You should make sure that patient is euvolemic prior to any surgical procedure. And you can consider functional hemodynamic monitoring like echocardiogram or arterial line monitoring. And of course, monitoring of serum creatinine and the urine output is very important. And try to avoid hypo or hyperglycemia. One common encountered scenario is end-stage kidney disease patient on hemodialysis or peritoneal dialysis get admitted for operation, and we usually get called to help optimize and deliver the dialysis perioperatively. So generally, in principle, dialysis patients should be adequately dialyzed, be euvolemic, and have a near normal electrolyte panel before undergoing any surgery. And just to give some tips on how to go about this, of course, we renal team will always be very happy to help you manage the patient perioperatively. But some of the tips that you probably need to be aware of is the timing of dialysis. So preferably is the day before the surgery, and it's not sort of like you just slot in a dialysis slot one day before the surgery. So for example, if the patient is dialyzing Monday, Wednesday, Friday, then you should try to slot the operation on Tuesday so that the patient gets the regular dialysis on Monday and go for the operation on Tuesday. Additional dialysis prior to surgery without an indication does not improve outcomes. So we will usually not entertain any dialysis which is on addition to the regular dialysis that the patient is having. However, if the surgery is emergency kind of surgery and you need to pre-operatively optimize this kind of patients and you need to perform the surgery on the same day, then we should go ahead with heparin-free dialysis, and that is usually what we practice in our hospital. We should monitor the electrolytes and try to keep it as normal value as possible. However, we all know that is sometimes not exactly possible. So, of course, at a level which the anesthetic doctor, surgeon, and the nephrologist are comfortable with, we can still proceed. How about extraction and ultrafiltration? That should be targeted to or close to the dry weight. For perioperative management, we try to maintain normal electrolytes, optimize nutrition, and glucose control. If the patient is anemic, if it's symptomatic and very anemic, then of course transfusion of PEG cells is the most effective way. If there's some time, then we can consider intravenous iron. We have monofur, cosmofur, or venofur. Or you can even consider some erythropoiesis stimulating agents such as Recomon, Aranesp, or Misera. Dialysis excess patency is very important. We need to monitor that and maintain that perioperatively. If the patient is on a catheter, have to ensure the catheter bundle is adhered to and there's a reduced risk of a CRBSI. We know patients with end-stage kidney disease are more prone to complications, and if they develop hypotension, the vascular access may thrombose, so that needs regular monitoring. We do perform urgent dialysis for those with hyperkalemia and volume overload. And perioperatively, we try to optimize the control of blood pressure, not overtly low and not overtly high. And we all know that end-stage kidney disease patients are prone to bleeding because of uremic platelet dysfunction and because they receive heparin in their dialysis 3 times a week. To minimize the risk of bleeding, what we can do is things like we hold the antiplatelet if they are on. We do heparin-free dialysis and adequately dialyze them so that the urea remains low. There is an arbitrary number of urea of less than 20 pre-op, and but that is not well studied. But we usually try to keep to that because we know if the urea is much higher, then the chances of getting uremic platelet dysfunction is higher. Even very bad hyperparathyroidism can also cause very bad anemia and also promote bleeding. So adequate or acceptable Ckd MBD control is actually very important. And we do sometimes even consider desmopressin prior to operation to reduce the risk of bleeding. So this is my last slide. For conclusion, I think chronic kidney disease is an independent risk factor for perioperative acute kidney injury on chronic kidney disease. It's also an independent risk factor for cardiovascular events and also mortality. So it's very important for us to identify and risk stratify patients with CKD to improve the clinical outcomes. Pre-operative evaluation in patients with CKD remains challenging, and this should be of a multidisciplinary approach. I would like to end my talk with a slide, and this is a study from the same author, Mersch, and this was published in Intensive Care Medicine 2017. and is talking about shifting the paradigm of AKI and to prevent AKI. So this study actually looks at early recognition of acute kidney injury risk combined with clinically guided treatment, and this reduces the occurrence of moderate to severe AKI by more than 33%. If you look at the figures, it's quite alarming. This is mainly in cardiac surgery patients. Acute kidney injury actually strikes in 30% of cardiac surgery patients. So means every 3 patients you admit for cardiac surgery, 1 of them will develop acute kidney injury. This will lead to 2 to 3 times increase in hospital costs, a longer hospital stay of even up to 6 days, and there's a rise of hospital mortality of 10-fold. When they develop an AKI, they also have 9 times higher risk of chronic kidney disease in the future, and there's a 2 to 3 times greater chance of readmission for other problems. And that ends my talk. Thank you.